Cardiology, Sir Gangaram Hospital, and it's an honor for me to be a part of this postgraduate clinics in pediatrics. I remember when I was in pediatrics, I didn't know much about cardiology, to be very frank. But now, at this point, I know that if we have taken proper history and examination before echo, we almost know the diagnosis. So that's why this approach is very important, especially for the pediatrics. The approach to history, at what age the child is presenting, how is the child presenting, how is it the child progressing, then at least we can start the basic treatment and we can counsel the family. So that's why clinically it is important. And also in your exams, the long case will be there for pediatric cardiology. So both ways this is important. So I hope this will be an important session for all the pediatric fellows. Over to you, Ananya.
Hello, ma'am. My topic is approach to a child with cyanotic congenital heart disease. Here
Okay.
is a one
So
and
just
one and
interrupting in between, just one thing. So as you progress with each slide, I'll be asking certain questions. The questions will be side by side so that
yes, ma'am.
the connection is maintained, right?
Yes, ma'am. Yes,
And
ma'am.
if anyone wants to answer, they can just type in
Yes,
during
ma'am.
this. Yeah, sure. Continue.
So here is a 1.5-year-old male who presented with the chief complaints of bluish discoloration of the lips and nail beds noticed at 4 months of age and easy fatigability while playing since 15 months of age. History of presenting illness. The child was born at term by LSCS delivery with immediate cry after birth. There was no history of NICU admission and the neonatal period was uneventful. The child was asymptomatic till 4 months of age as per parents with normal feeding and activity. At around 4 months of age, mother noticed bluish discoloration of the lips, the tongue, and the nail beds, for which consulted nearby doctor, for which given medication and no investigations were done. At 6 months of age, parents noticed that there was an episode of prolonged crying, during which bluish of lips and nails increased, which was associated with rapid breathing. This episode lasted for around 3 to 4 minutes, following which the child became irritable, restless, and appears tired. This was resolved when the child was consoled by the mother and was put on mother's hip with legs flex position. Similar episodes occurred 2 to 3 times per month, but recovered within 5 minutes.
Okay, so wait. We'll halt
Yes,
in each slide. You have to wait at the end,
yes,
right?
ma'am.
So come to HOPI,
Yes, ma'am.
history of presenting illness. Okay. So we have a lot of information in this slide.
Yes,
In
ma'am.
first point, you're saying that the child had an uneventful perinatal period,
Yes,
right? There
ma'am.
was no
Yes, ma'am.
cyanosis at birth. So the
Yeah.
cyanosis started at 4 months.
Yes,
So what do
ma'am.
you think this, the first line, that at 4 months of age, the parents noted that the child had cyanosis. So is this a
Yes, ma'am.
cyanotic heart disease? Is this peripheral cyanosis? Is this central cyanosis? What do you think by this statement? When the parents first told you that the child is having bluishness of lips and tongue at 4 months of age. What do you conclude by this
Uh,
line?
this can be central cyanosis.
Okay. So how do you say
Uh,
that it is central cyanosis? Why are you saying that is
because
the
there
central
was a
cyanosis? Maybe it's, yeah, maybe it's
bluish
winter
discoloration
months
of the
and
tongue,
okay. So do you think that
lips.
the parents will note the tongue is blue in discoloration? Can they give this much of history?
No,
Or
ma'am.
will you
Like
ask
mainly
something?
hands and feet. I asked them. By
Okay.
asking them, they told me. Basically, they told me nail beds and
Hmm.
peripheral cyanosis history. They told by themselves.
Okay. So peripheral cyanosis, that means it is due to cold. So that is not a heart disease. How do you say that it is a cyanotic heart disease? So most
Uh,
important, tongue, they may not note because the baby is just
yes.
4 months of age. You may say that there was lips which were turning blue, right?
Yes,
If the
ma'am.
nail beds are
Yes,
blue,
ma'am.
that is due to peripheral cyanosis, due to
Cyanosis.
temperature,
Yes, ma'am.
right? If the
Yeah,
lips
ma'am.
are blue and if the tongue, they have told that is a very good history, then
Yeah,
you may
ma'am.
suspect that it is a cyanotic heart disease. Now, one thing very
Yes, ma'am.
important, which you have to again ask them and reascertain them, that this cyanosis was not present at birth. right?
Yes, ma'am.
Because the differential
Yes.
diagnosis totally differ if the
Yes,
cyanosis is
ma'am.
at birth versus the cyanosis is at 4 months of age.
4 months of age.
Okay, so
Yes,
what are the
ma'am.
two important differentials when you say that the cyanosis is present at birth
Uh,
and when the
at
cyanosis is
birth, there
present
can be
in infancy?
transposition of great TG.
Yes,
Transposition of
very
great
good.
artery can cause at
Hmm.
birth,
Okay, okay.
and other
And
than
in
that,
infancy?
uh, and infancy, of tetralogy of Fallot, ma'am.
Okay. So for you or for all the pediatric fellows, two important diseases you have to remember. If the parents are giving
Yes, ma'am.
history of cyanosis at birth, the most important one is transposition of great arteries, right?
Yes, ma'am.
TGA, TGA with intact septum, right?
Yes,
This
ma'am.
will present with cyanosis at birth. There are other
Yes, ma'am.
differentials also, but the most common one is TGA. If they are
Yes,
saying
ma'am.
that the child was completely asymptomatic and they have noticed till 4 months of age, this may be the
Yes,
case
ma'am.
that the cyanosis was present at birth, but they have noticed it later, right? So
Yes,
this
ma'am.
depends
Yes,
upon
ma'am.
parents. But still,
Yes, ma'am.
if you can differentiate it whether the cyanosis was present at birth or later, it will give you an important clue that to which disease you are progressing. So this is first
Yes,
thing,
ma'am.
cyanosis.
Yes, ma'am.
Now in second sentence, you have told about certain incident. So what
Yes,
is this
ma'am.
incident? What happened at 6 months of age?
So at 6 months of age, because of the trigger, like while crying or feeding,
Okay,
because of that, there was a hypercyanotic spells, that is TED spells.
okay. Can you
Uh,
describe what
so
is the mechanism of this TED spells?
so basically, because of the trigger that causes catecholamine release, that causes infundibular spasm, which causes right ventricular outlet obstruction. So because
Okay,
of that, that can worsen, that causes increased right to left shunting. So because of that, in systemic circulation, the deoxygenated blood goes and hypoxia will be there. That will lead to metabolic acidosis, that further leads to that further triggers the respiratory center, and further leads to hyperapnea, and further lead to increased venous return. So this turned into a vicious cycle.
okay. So you are partially correct in this, but not completely. So initially, we used to think that the first trigger is causing infundibular spasm, and that is the
Yes, ma'am.
starting point. But this is not
Yes, ma'am.
actually the case. Now there are various
Yeah.
theories of why cyanotic spells or TED spells do occur,
Yeah.
and the most
Yes,
common
ma'am.
one is the Morgan theory. So they say
Yes, ma'am.
that whenever there is any trigger, the child is crying or straining or early in the morning, the respiratory centers they get stimulated. So due to
Yes,
respiratory
ma'am.
centers which are stimulated early in the morning or during crying, when the child will inspire with the deep inspiration, the venous return to the right side will increase, right?
Yes,
Because
ma'am.
if the child is
Yes,
taking
ma'am.
a deep breath, so more blood will
Yes,
come to
ma'am.
the right side. That more blood is accumulating from RA to RV. Now there is PS. So this more blood will go through VSD into LV, into aorta,
Yes,
and
ma'am.
some blood will go
Mm.
to pulmonary arteries. That's why
Yes,
the
ma'am.
cyanosis is there. So the trigger
Okay.
is after the trigger, the respiratory centers are. So this is the most
Yes, ma'am.
accepted theory. So whenever you are
Okay.
asked why the
Morgan's
state
theory.
spells occur, yeah. So you have to start with after any trigger or during early when the child wakes up after a deep sleep, then the respiratory
Yes,
center
ma'am.
occur. That's why you have
Yes,
to take
ma'am.
history. What all histories do you have to take in this cyanotic spell? First of all, at what time have they occurred?
Yes, ma'am.
Early morning
Um,
or late night. So most probably these spells are in early morning. Then,
yes, ma'am.
how
Any
do you
other
differentiate
trick?
that this at 6 months of age, supposedly, this is a breath holding spell? How do you differentiate that it is a TED spell and not breath holding spells? Because breath holding spells are more common. They are common
Yes,
at this
ma'am.
age group. So, what is the age group
Yes,
of breath
ma'am.
holding spell?
Breath holding usually presents at 6 months to 6 years of age.
Okay. And what is the
Usually,
age group
the
of
trigger are
TED spells?
anger.
What is the
Age
age group of
age
TED
group
spells?
2 months to 2 years.
Okay. So, they are overlapping. 6 months is overlapping in both of them. So, how do you
Yes, ma'am.
differentiate that it is a TED spell and not a breath holding spell? Most important
Uh,
point,
there
if
is
anyone
no
could answer.
deep rapid breathing.
Yeah. So,
Hyperapnea
yes.
is present in
So,
the TED smell, but
okay. As the name suggests, breath holding spell, right? So the child has
yes,
to
ma'am.
hold the breath. There
Yes,
has to
ma'am.
be inspiratory or expiratory hold. So when the mother will say that the child was crying a lot and then suddenly the child held his breath and
Yes,
then
ma'am.
suddenly turned blue. That is a
Yes,
typical
ma'am.
history of breath holding spell. But if the
Yes, ma'am.
parents will say that there was increase or rapid breathing during early morning
Yes,
and
ma'am.
then the child turned blue, right? So this
Yes,
is
ma'am.
dead spell. So
Yes,
partially
ma'am.
these can overlap, but still if you have taken history in a very detailed manner, then you can differentiate between them that whether this is a breath holding spell or a dead spell, because this is important. The age group is
Yes, ma'am.
overlapping, and you may
Yes,
be
ma'am.
thinking that this is a cyanotic heart disease, but it actually turned out to be a benign lesion. It's just a breath holding spell,
Yeah,
right?
ma'am.
So you have to know
Yes,
what is
ma'am.
the trigger, what is the mechanism, and what all do you have to ask in history. So what else do you ask for this breath holding spell, for this TET spell?
That
So you
spell,
asked how do they
any,
occur,
yes, ma'am.
initiation, then
Any triggering factor like crying,
okay, then
forceful feeding or
okay,
defecation, any
that
fever.
is one thing. That is one thing. Precipitating factor. The second
Yeah,
point.
ma'am. Uh, Second point, any previously diagnosed congenital heart
No, 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 no. I'm
disease.
just asking about this TET spell.
Yes,
What all points will
yes,
you
ma'am.
cover when you ask about TET spell?
Like
First is
what
what is the
is
trigger?
the duration? Yes,
Okay.
ma'am.
Second is duration. Third,
Duration. Third, does it stop after some manure? Like,
yes. So how does this
yeah,
abort it? On its own
yeah.
or by doing some manual? So you have
Yes,
written
ma'am.
one line that this resolved when the child was consoled by the mother and was put with hips and legs flexed. So you
Yes,
know
ma'am.
that this aborted with this, but did the mother knew about this?
No,
She
ma'am.
knew
I
that
just
by flexing.
asked.
Huh. So you ask and you
No.
interpret that by
Yeah,
doing
ma'am.
this maneuver. Otherwise, the mother will just say that when the child had this blue episode, the child was just kept on this lap and then that episode aborted. But then you'll ask it,
Yes, ma'am.
what was the position in which you were holding the baby? Then you'll
Yes,
come to
ma'am.
know, okay, so this was just a aborted method. The mother didn't knew
Yes,
about
ma'am.
this, but she has done this. That's why the breath holding spell has aborted. Now, next
Yes, ma'am.
thing you'll ask about this breath holding spell is what were the complications, or what was
Yes,
the
ma'am.
after episode of this breath holding spell? Did the child was very drowsy, restless, or did the child had seizure, or did the child had unconsciousness? So, what was the complication? What was the after effect of this breath holding spell? That also you have.
Here, the child was irritable and restless and appeared
Okay.
tired.
Okay. Then next thing
Yes,
is what is the frequency? How frequent are these breath holding spells? Why is this
yes,
important
ma'am.
frequency? Why are you asking
Because
this?
it tells about the complication, how severe the
Severity.
how
Yeah.
severity of the infundibular spasm.
So it tells about the severity. If the baby is
Yes, ma'am.
having breath holding, this again and again saying breath holding spells. If the baby is having
Yes, ma'am.
TET spells very frequent at a very early age, it denotes that the baby or the child is having severe TOF, will need
Yes,
an
ma'am.
urgent surgery
Yes,
earlier.
ma'am.
Right? So you are saying
Yes,
that
ma'am.
similar episodes occur every 2 to 3 times per month and recover within
Yes,
five
ma'am.
minutes. So they haven't
Yes,
taken
ma'am.
any medications for this
They had
initially.
taken.
Initially, when you are
Initially,
telling,
they had not. No, initially
okay,
they had not taken, ma'am.
okay. So they just abort it on its own.
Yes,
Okay,
ma'am.
one more question and a very important question.
Yes,
Why
ma'am.
does this TET spells started at 6 months of age and not around 4 months of age or around 2 months
Uh,
of age or before this?
so, yes, ma'am. That's mainly because in at the time of birth,
Hmm.
this patent ductus arteriosus, sorry, yeah, ductus arteriosus will be patent, ma'am. Because
Okay.
of that, oxygenated blood will be passed through the pulmonary
Okay.
flow.
So this is one
And
point. Second point. Hmm.
one more reason is because of the fetal hemoglobin.
Okay.
And one more reason is the obstruction which is present at the birth, and it increases in severity as the child ages.
Okay. So, not the
And because of,
obstruction. See, this
yes,
point is
ma'am.
not correct. Whenever we say
Yes,
that the
ma'am.
child is having TOF, it's always severe PS. It's not that the child was not having severe PS at birth. It's just that the
Okay.
infundibular spasm can
Yes, ma'am.
increase, which is causing these TET spells. The child was
Yes,
having
ma'am.
that severe obstruction, but the spasm is increasing because of the
Yes, ma'am.
theory which we have already told. So
Yeah,
that is
ma'am.
one reason. So if the PD is present or due to fetal
Yes.
hemoglobin, which has great
Yes,
affinity
ma'am.
with oxygen, and due to
Yes, ma'am.
infundibular spasm. This doesn't
Yes,
occur
ma'am.
at birth or before 2 months of age. It only
Yes,
occurs
ma'am.
after 2 months of age. That's why it is common after 2 months. And till what age does this occur? This dead spells?
Uh, that spell six
Mostly
months to two
2 years.
years.
Yeah. So why
Yes,
two
ma'am.
years? Why not after 2 years?
After 2 years, because child himself will get to know the how to recover from like
Hmm.
squatting
Hmm.
position.
So these are known
The-
as squatting equivalents.
Yes, ma'am.
So all the PGs and all the fellows can write down all these questions which I'm asking. These are the usual questions which are asked. So after
Yes,
two
ma'am.
years of age, the child is having squatting equivalents due to
Yes,
which
ma'am.
the child acquires certain positions and these
Yes,
uh,
ma'am.
dead spells abort.
Yes,
Secondly,
ma'am. Um,
other things, collaterals may develop after two
yeah,
years of
ma'am.
age.
Collateral circulations.
Huh.
Yes, ma'am. Um,
That third thing, the infundibular become fixed. It may become fibrotic. So the
okay.
dynamic component which is causing spasm and causing these TET spells, that is
Yes, ma'am.
not there after 2 years of age. So these are the
Okay.
reasons why it is
Does
not
not
there
occur
after two
after
years
two
of
years.
age. Okay,
Yes, ma'am.
so we have covered two
Yes,
things.
ma'am.
The child is having cyanosis and the child is having a TET spell, which is very frequent. Right, continue.
Yes,
Next
ma'am.
slide.
The child was evaluated at the nearby hospital where a 2D echo was performed and a
Hmm.
congenital heart disease was diagnosed and was
Okay.
given a medication which used to be taken by the child 3 times daily. The family was informed regarding the need for surgical correction and medical therapy was initiated. However, due to financial constraint, definitive treatment could not be pursued and the child was subsequently lost to follow up. The child attained age appropriate developmental milestone and started walking independently at around 15 months of age. Following ambulation, parents noticed easy fatigability while playing compared to other children of similar age. The child required frequent period of rest and often sat down in between playing activities before resuming them.
Okay.
In view of
Wait. I told you with each slide you have to wait because there'll be questions following them. Right?
yes, ma'am.
Okay,
Yes,
so in
ma'am.
this slide, you have again told a lot of information. The first
Yes,
thing
ma'am.
says that the child was evaluated for this in a nearby hospital where echo was done. So, at what
Yes,
age
ma'am.
roughly the echo was done?
After 6 months, ma'am. After
So,
eight.
after 6 months, the child is
Yeah.
now, what is the age now? 1.5 years. So, after
Yes,
six
ma'am.
months, the echo was done, and they were already told that the child is having a CHD, a congenital heart
Yes, ma'am.
disease, for which they have been given medication, which was taken
Yes,
three
ma'am.
times a day. Do they remember the name of medication?
They don't remember the
Yes.
medications, ma'am. They
And what
just
do you think this medication could be?
so I think it's non-selective beta blocker like propanolol would have been
Yeah.
given.
Okay. So
Uh,
always, whenever you ask history of medications, mostly the
yes, ma'am.
parents do not know what medication is. If they
Yes,
have
ma'am.
brought the medication, then that is a different thing. If they haven't, you just
Yes,
have
ma'am.
to ask how frequent are you
Yes, ma'am.
giving. So any
Yes, ma'am.
medication giving for a CHT given very frequently 3 times a day, most probably it is propranolol, right?
Yes, ma'am.
So
Yes,
this
ma'am.
again reconfirms that the child was having a cyanotic heart disease for which propranolol was given. One thing.
Yes,
Secondly,
ma'am.
the child was informed, the family were informed that the parents had to
And
undergo a surgical correction for the child and medical therapy
yes,
was.
ma'am.
So,
Yes,
at
ma'am.
what age this surgical correction was, they have been told? The child was at
Usually,
what age?
if the child was at 1 year of age,
So, at this time, the
usually,
child was 1 year when have been told that the child will be needing surgical correction.
yes, ma'am.
Have they gone for follow up after the first echo?
No, ma'am, they haven't gone.
Okay. So, at 6 months, echo was done, medication was
Yes,
started,
ma'am.
and then that time only they were told about surgical correction? Or were
They
they
were
told that
told
in future it will be needed?
in future around 6 to 12 months it will be needed.
So they have already
Uh,
been told about the timelines of this. And
yes,
medical
ma'am.
therapy. What
Uh,
else medication could be given along with this? Propranolol, which you are telling
prop,
TDS.
One is propanolol, ma'am.
And
One more is
you think
I,
something else must have been given with this?
iron supplementation
Hmm. Do you
or
think they have given diuretics also with this? Is it given?
No, ma'am. Diuretics are
Okay.
contraindicated
Yes. So that is a
because,
very important thing, that
yeah,
you
ma'am.
never and never give diuretics in this.
Yes,
Just
ma'am.
propranolol and iron. These are the two
Yes,
things
ma'am.
whenever you suspect that the child is having TOF, like
Yes,
physiology,
ma'am.
you give
Yeah,
this
ma'am.
propranolol and diuretics. Okay.
Yeah, ma'am.
So they,
Yes,
due to
ma'am.
financial constraints, they haven't pursued for this further. Okay. Now, third point, you have told that the child was developmentally normal. So what do you conclude by
Yes, ma'am.
this? Why have you taken this history that the milestones were normal around 15 months of
Uh,
age, and why is it important? Why do you think that the child would be
because
having?
neurodevelopmental, there was no complication of TOF
Okay. So due
because
to
chronic
frequent,
hypoxia,
yes, due to
uh,
frequent TED
chronic.
spells also, the
Yes,
child is
ma'am.
having frequent TED spells, there are
Yes,
chances
ma'am.
that the child can have neurological complication. So by this line, you're
Yes,
saying that
ma'am.
the milestones were normal. That means till now, no neurological complication is there
Yes,
at
ma'am.
around 15 months
Yes,
of
ma'am.
age. Okay,
Yes,
the
ma'am.
last thing you're saying, very important thing, that now the parents are very good. They are giving such a good history in this. So now
Yes,
the
ma'am.
parents are saying that they have noticed the child is having easy fatigability. So what do you mean by this? Why is the child is having fatigability while playing?
So mainly because child started playing, so that causes increased energy, oxygen demand for the child.
You don't say energy.
So
It is the correct term
sorry.
is oxygen demand, right?
Yes,
Okay.
yes, ma'am. Yes, ma'am.
Then,
So because of that, already child is in hypoxemia. For increased
hmm,
oxygen demand, instead of aerobic metabolism, anaerobic metabolism will happen. That lead to lactic acidosis that causes fatigability.
yeah, this may be the reason that the just
Yeah.
you can say the oxygen demand is increased while playing. So that is causing easy
Yes, ma'am.
fatigability. So how did they
Yes,
notice
ma'am.
that the child is getting fatigue, and how does the child cope up with this?
The child gets tired easily
Okay.
uh, compared to other normal child
Hmm.
who can play for like longer period. The child easily rests for
Gets
some time.
fatigue. Okay. So
Yeah,
whenever
ma'am.
you tell about any of these important cardinal features, these are called cardinal features of cardiology,
Yes, ma'am.
which
Yes, ma'am.
includes dyspnea, fatigability, palpitations.
Yes,
These
ma'am.
are all cardinal features. So you have
Yes,
to
ma'am.
classify them according to NYHA classification. So we have NYHA classification. So whenever you come
Um,
across certain history, you have to categorize that the parents were saying that the child is having easy fatigability, and according to
yes,
NYHA
ma'am.
classification, this is class 2 or grade 2.
Yes,
Okay.
ma'am.
So you have to ask
Yes, ma'am.
how much the child can move, how much the child can play, how easily the
Yes,
child gets
ma'am.
fatigue. So this thing you have to
Yes, ma'am.
add, right?
Yes,
Now,
ma'am. Yes,
now
ma'am.
how does this fatigability settled? How did the child cope up with this?
Once the child gets rest,
Hmm.
there can be because of like hyperventilate compensatory hyper
The child started hyperventilating with this. When the child got
or
easily fatigued, what did the child do?
uh,
You have
squatting
written in this
position.
line. Yes, you have written in here that the child required
Yeah.
frequent periods of rest. So
Yes, ma'am.
now, since you are taking history, you know about that, you have already made a diagnosis in your mind, a provisional diagnosis.
Yes.
Then you can ask
Yes, ma'am.
specific question. How did the
Yeah.
child took rest in between? Did the child sat
Yes,
down?
ma'am.
That in
Yes,
which
ma'am.
position? You can ask this direct
Squatting.
question. Huh. Then you come to
Yes,
know,
ma'am.
okay, the child is taking this squatting position. See how beautiful
Yes,
it
ma'am.
is that the parents also doesn't know the diagnosis, the child also doesn't know the diagnosis, but they
Yes.
are aborting this
Yes, ma'am.
spell or aborting this episode, right?
Yes,
So
ma'am.
this is
Yes, ma'am.
important how they have
Mm.
come across through this.
Yes, ma'am.
Okay. So the next slide.
In view of recurrent bluish discoloration episode and easy fatigability, the child was evaluated at a higher center and was subsequently referred to our hospital for definitive evaluation and
Okay.
management.
Okay. Next slide.
So there was no history of excessive sweating during feeds.
Okay.
There was
So
no history
now,
of
just
during.
one thing. So now you're
Yes, ma'am.
telling about the negative history. So whenever you have
Yes,
taken
ma'am.
a chief complaints, you have taken history of present illness, you have to
Yes,
proceed
sir.
for negative history. Now, negative history is divided into two parts.
So
In
I wanted
any
to rule
case,
out any.
just I'm telling, then you can proceed
Yes,
further.
ma'am.
So
Yes,
negative
ma'am.
history is taken into two parts. First is you have to rule out differentials, that you have already made one diagnosis in your mind when you're taking history, but still you are not very sure that whether this is the diagnosis or it could be something else also. So the negative history is to rule out those differential diagnoses. And second is, now you've already made, no, this is the diagnosis only. Then you have to rule out complications. So you have to
Yes,
take
ma'am.
negative history into two parts, the differential
Yes, ma'am.
and the complications. So first of all,
Complications.
about differentials. What negative history you have taken for differentials?
So I took about to rule out congestive cardiac heart failure, which is seen in cyanotic heart disease like VSD, patent ductus
Sorry, sorry,
arteriosus.
sorry. You have
Uh,
taken, huh, just repeat it. You have
as ma'am,
taken history for CHF, which is present in cyanotic heart disease.
VSD,
Cyanotic heart
which is
disease.
which is present in VSD, left to right
Wh-
shunt,
So that
acyanotic.
is acyanotic. It's not
Yes,
cyanotic.
ma'am.
You
Yes,
can't
ma'am.
confuse these
Acyanotic
terms.
heart disease.
Cyanotic and
Yes,
acyanotic are different. So you have to
yes,
rule out
ma'am.
acyanotic. But why are
Yes,
you
ma'am.
taking history of acyanotic disease? Now you're already sure that the child is having cyanosis. Now you already know that the child had cyanotic spell and the patient was taking this propanolol and they were told about surgery and everything. Now you've already made your mind
Yes,
that it could
ma'am.
be tough. That then why are you taking history for this increased flow? Just think the history
Because
is correct, but why increased flow? But at this point,
uh,
you are saying that it is not cyanotic heart disease.
no,
Are you
ma'am.
implying this?
I wanted to be completely sure
Now,
because
are you not
usually in
sure
cyanotic,
about these? No, no, something
I'm sure.
else. So
Uh,
for this, you have to know how do you divide the cyanotic heart disease. So at this
yes, ma'am.
point, you have already taken chief complaints, you have already taken HOPI. You're already
Yes, ma'am.
sure that the child is having a cyanotic heart disease. So how do you
Yes, ma'am.
divide cyanotic heart disease? Based on
One is increased pulmonary blood flow and
yes.
decreased pulmonary blood flow,
Yes,
ma'am.
so that is important.
So
So this you're
yes, ma'am.
already sure that the child is having a cyanotic heart disease, but
Yes, ma'am.
whether it is increased flow or
Or
decreased flow.
decreased blood flow. Yes,
So
ma'am.
if it is a cyanotic heart disease with increased flow, then the child will have these features. Cyanotic
Yes,
heart disease
ma'am.
with increased flow, which is what are these
Yes, ma'am.
features?
Excessive sweating during
Sweating,
feeds, feeding
hmm,
yes, ma'am. Feeding
feeding
difficulty,
difficulties,
and
recurrent
history of any
LRTI.
because
Okay.
in
So just
recurrent
what
LRTI,
what are these
because
diseases? CHD with increased
uh,
pulmonary blood flow?
one is transposition of great artery, ma'am. Total anomalous pulmonary venous connection and truncus arteriosus, ma'am.
So the classical is truncus with increased pulmonary blood flow,
Truncus
single
arteriosus,
ventricle with
yes, ma'am.
increased pulmonary blood flow, and then
Yes,
TJ with VSD,
yes,
right?
ma'am.
And
Yes, ma'am.
TAPVC, not much, but then could be there,
Okay,
right?
ma'am.
So whenever you
Yes,
take
ma'am.
history, you have to have in mind that I know this is a cyanotic heart disease, but this could be
Yes, ma'am.
cyanotic heart disease with increased flow or decreased flow. Now, since you have
Yes,
taken
ma'am.
this history, it is not present. So it is cyanotic
Yes,
heart
ma'am.
disease with which flow?
Decreased pulmonary blood
Decreased
flow.
flow. Okay. So by
Yes,
this
ma'am.
time, you know that it is a cyanotic heart disease with decreased flow. Okay. Now,
Yes, ma'am.
second part of negative history is
I want to rule out any complications of
yes.
TOF,
So
ma'am.
what are these
One is
complications?
neurological symptoms. Like
Okay.
there was to rule out basically in TOF if there is hypoxemia, which is a polycythemia condition.
Hmm.
Because of that, there can be brain abscess
Hmm.
and cerebral sinus venous thrombosis and stroke
Okay. Hmm.
complications.
Hmm.
So I
Hmm.
wanted to rule out that. So
Hmm.
there was no history of any focal neurological deficit or any history of weakness of the body or decreased
Oh,
movement of the limbs.
okay. So this is CNS complication. Second
Yes,
complication.
ma'am. I wanted to rule out about infective endocarditis.
Hmm.
So there was no history of any prolonged fever.
Okay. Anything else you want to ask about prolonged fever or any rashes,
हाँ ma'am. Rash. Yes,
rash
ma'am.
or hospitalization, prolonged fever? Acha, do you
Yeah,
think there
ma'am.
will do you think there will be infective endocarditis in TOF? If yes, then at what site this bacteria can
Valvular.
lodge?
In the
Yes.
valvular side, ma'am.
Okay. Which valve
Uh, Pulmonary,
or
infundibulum, or
infundibulum? No.
uh,
So bacteria always lodge there
in the
where there is
high pressure
stasis,
gradient.
stasis, somewhat
Um,
stasis,
yes, ma'am.
right? So PS,
Yes,
or if
ma'am.
there is associated AR,
Yes, ma'am.
when the valves are getting damaged, the blood is not
Yes,
going
ma'am.
much there. If the blood is going, they'll all get flushed out. If the blood is not going
Yes,
much
ma'am.
there, then the PS and AR. So these are the two sites where infective endocarditis can occur, but it is rare in
Yes,
top.
ma'am.
It doesn't occur.
Yes,
Okay. The last you are asking about vomiting, convulsion, unconsciousness. What is this?
yes, ma'am. To rule out same, ma'am, neurological
Which
symptoms.
complication?
Uh,
This is for
this is uh, s- sa- brain
Mhm.
abscess.
Cerebral abscess. Cerebral abscess. You've
Yes,
taken
ma'am.
CNS histories also, right? So in
Yes,
cerebral
ma'am.
abscess, you get this history. Projectile vomiting, convulsions, unconsciousness,
Yes, ma'am.
seizures can
Yes,
occur, right?
yes,
So you have
yes,
taken
ma'am.
history into two parts. You have ruled out that it
Yes,
is
ma'am.
CCHT with increased flow, and you've ruled out
Yes,
that there
ma'am.
is no complication till yet. Because why there is no complication even after so many spells? What do you think?
Mm,
Just one
uh,
hypothesis that the child is already taking medications for this at from an
yes,
earlier
ma'am.
age.
Yeah. Yeah.
Yeah. The
Yes.
child was not taken any medication and very frequent spells, then
Yes,
any
ma'am.
complication will occur. But this is not always the case. Still, the
Yes,
complications can
ma'am.
occur. Right. Move
Yes, ma'am.
forward. Next slide.
So birth history.
Okay.
It's a full-term baby. Breech presentation delivered by LSCS.
Mm.
Immediate cry after birth. Birth weight was 2.8 kg. No resuscitation needed. No NICU stay. Uneventful neonatal period.
Now, so, what do you imply from this slide? Why birth history is important in a heart
Uh,
disease, congenital heart disease?
Basically, to differentiate between any complication, perinatal complication that can lead to other cyanotic heart disease like transposition of great arteries.
Complication, or basically to say that it was uneventful. If the child was having
Yes, ma'am.
TGA, then the child would have been
Yes, ma'am.
cyanosed, right?
Sinus. Yes,
Or
ma'am.
there could have been increased respiratory efforts,
Yes, ma'am.
right? So you have ruled
Yes,
out
ma'am.
that it was uneventful. There was no resuscitation required, no NICU stay. The child have been the newborn have been discharged from the
Yes, ma'am.
hospital. That means there was
Yes,
no
ma'am.
issue at that time, most probably.
Yes.
Still, it could be
Yes, ma'am.
missed, but most probably there was no issue. Not a major
Yes, ma'am.
congenital heart disease at that time.
Yes,
Okay,
ma'am.
next.
Developmental history. Gross motor neck holding achieved at 3 months of age. Sitting
Hmm.
without support at 7 months.
Hmm.
Standing with support at around 10 to 11
Okay.
months.
So
Independent
you
walking at 6.
Yes. So you don't have to
Yes,
tell
ma'am.
individual developmental history in this cyanotic heart disease patients. You can just
Yes,
say
ma'am.
that the developmental history was normal. And if the
Yes,
examiner
ma'am.
asks you what were the milestones, then you have to elaborate. Otherwise, you can say that developmentally the child was normal.
Normal. Yes, ma'am.
Right?
Yes,
Next.
ma'am. So nutritional history. Child was exclusively breastfed for first 6 months.
Hmm.
Complementary feeding was initiated at 6 months. So the calories intake per day was 900
You
kilocalories.
just have to tell
Recommend
the deficit was
160
60
kilocalories
and
and
protein.
2 grams per day
uh,
of deficit.
So this is not much. That means the child was
Yes,
well
ma'am.
fed. This again
Yes,
rules out
ma'am.
one thing. What?
Failure to thrive,
Failure to thrive. Why? Why does it
poor
occur?
growth.
And which it is more common? Which heart disease it is more common?
In cyanotic heart disease, ma'am.
No, not cyanotic, but actually acyanotic heart disease with CHF or with
Okay.
cyanotic heart disease with increased flow. Because a lot of
Okay.
energy is needed. The heart is in failure. A lot of energy is needed. The child may not
Yes,
be
ma'am.
able to take that much of calories and proteins.
Yes, ma'am.
Right? The child is having a
Yes,
large
ma'am.
VSD. Then
Yes,
the child
ma'am.
will have frequent suck cycle. The child won't
Yes,
be able
ma'am.
to take so much feed. So this also
Yes, ma'am.
rules out that it was not an increased flow situation,
Yes, ma'am.
right? These are just pointers in history which you are asking just to be very sure that yes, this is the diagnosis before you have
Yes, ma'am.
confirmed by echo.
Yes, ma'am.
Okay, next.
Yes, ma'am. Immunization. Immunized appropriately for age according to the National Immunization Schedule. BCG scar was seen. No missed vaccination.
Okay. So why this is important? Immunization.
So that any immunization is important so that that won't trigger any infection in the child.
Hmm. Already
Uh,
cyanotic heart disease are having low
yeah,
immunity,
immunity.
and if those patients haven't taken the immunization well, the vaccination well, then
Yes, ma'am.
then they may have more complications. So the
Yes, ma'am.
immunization history was appropriate. You have seen the
Yes,
BCG
ma'am.
scar also.
Yes, ma'am.
And just a pointer that these TOF patients are more prone for pulmonary COX because of the
Yes,
VQ
ma'am.
mismatch in
Okay,
lungs.
ma'am.
That's why
Yes, ma'am.
this is also important. Not at this age,
Okay.
maybe later, but then
Yes, ma'am.
in adult also, this is more common,
Yes, ma'am.
right?
Yes, ma'am. Family history, non-consanguineous marriage, no family history of any congenital heart disease, no family
Hmm.
history of sudden cardiac death, no similar illness in the siblings.
Okay, so what do you think that how frequent are these heart disease in families? Supposedly, if the child had one sibling and
Yes,
this
ma'am.
patient is having TOF, what frequency or how much common
Uh,
would have been
like
heart disease?
around 5 to 6% of risk will be there in the
Huh.
sibling
So just
if
half
there
of this,
is.
2 to 3%.
Okay, ma'am.
So 2 to
Sorry.
3% is there, but
Yes,
will
ma'am.
the second child will also have TOF only?
No, ma'am. There can be any other congenital heart
Any.
disease.
So this 2 to 3
Yes, ma'am.
percent is of any CHD, not just
Yes, ma'am.
TOF. If a
Yes, ma'am.
child is having this CHD, which is TOF, then the other
Yes,
child
ma'am.
can have any CHD. It's around 2 to
Yes, ma'am.
3%. So that
Yes,
is
ma'am.
important family history of congenital heart disease. What was
Or
this
any
family history of
syndromes.
sudden cardiac death?
Uh, I don't.
So this is to rule out
Is
arrhythmias.
any? Okay,
Arrhythmias
ma'am.
also sudden cardiac death. So
Okay.
just to rule out that the child is not having rhythm issues and no similar history
Yes,
in
ma'am.
siblings. And a
Yes, ma'am.
non-consanguineous marriage. Why?
Yes, ma'am. Because there can be any like
Hmm.
autosomal recessive conditions in the child.
Okay.
Uh,
So what all syndromes do you think that this patient can have
uh,
is or
One is, ma'am, DiGeorge syndrome.
so that is very important to
That's
rule out DiGeorge
venlocardial
syndrome.
facial syndrome. Yes, ma'am. And
Uh,
then there can be Alagille syndrome.
Alagille, okay.
Yes, ma'am. And Down syndrome can be
How
there,
do you
but
forget
usually it
Downs?
is
The most common is
usually it
Downs.
is
It's not that Downs
80%.
won't be having TOF. Down
Yes, ma'am.
syndrome can have any CHD, or the most common EB canal, but can have
Yes,
TOF too.
ma'am.
So whenever you
Yes,
are asked
ma'am.
about what are the syndromes associated with any of the CHD, the first and foremost is Downs.
Okay,
Then
ma'am.
DiGeorge,
Yes,
very important. You have to rule out.
yes, ma'am.
What do you
Yes,
see
ma'am.
if just to rule out that this is not DiGeorge? One thing which we see in echo, if you know about this.
Uh, Echo.
Although no, I know it's difficult, but
Uh,
just if you know or
yes,
anyone,
ma'am.
what do we see in echo? Just
Hypocalc.
in echo, we cannot see hypocalcemia.
No, ma'am. Sorry.
Huh.
Uh, there can be the third overriding of
Huh.
aorta.
I know this is difficult. That's why I'm saying, okay, that's okay. So we see thymus. Thymus is very important
Thymus hypoplasia will be
because
there.
thymus hyperplasia or absent thymus is there in DiGeorge. That's why
Yes,
in
ma'am.
every TOF or any CHD or even in fetal
Yes, ma'am.
echoes, we look for thymus. That is very important. If thymus is
Yes, ma'am.
absent, always and always rule out DiGeorge by
Yes, ma'am.
genetics,
Yes, ma'am.
right? So that is
Yes,
one
ma'am.
thing. Okay, next.
Clinical summary.
So now
One
you're
and a.
summarizing your findings, just the history
Yes.
part,
Yes,
right?
ma'am.
Hmm.
Yes, ma'am. So, 1.5-year-old male child presented with cyanosis at 4 months of age, with cyanotic spell noted at the age of 6 months, along with easy fatigability noted at 15 months of age.
Mhm.
Developmental milestone was age appropriate. There is no history suggestive of heart failure, recurrent respiratory tract infection, or any neurological events or infective endocarditis.
Acha. So you have summarized this case that there is a child 1.5 years of age with
Yes,
cyanosis
ma'am.
since 4 months, with spells since
Yes,
six
ma'am.
months, with
Yes,
fatigability
ma'am.
noted later on, normally developmentally normal, with no
Yes, ma'am.
complications. So what do you think? What kind of heart disease is this? Is this a heart disease, first of all?
Yes, ma'am. It is a heart disease,
You are
but
very sure that it is a heart disease? How do you know? What is the criteria do we use?
uh,
Just the name of that criteria? These are the
NADA's
questions
criteria.
which could be asked. So the
NADA's
criteria is
criteria.
NADA's criteria, which says
Yes,
that
ma'am.
whether it is heart disease or
So
not. So one
there are
is cyanosis. So
major.
it is heart
Yes,
disease.
ma'am.
Okay.
Yes,
Then
ma'am.
second thing, which
Uh,
kind of cyanotic heart disease is it? High flow or low flow?
it is a low flow, ma'am.
Low flow, because you have ruled out through history that there
Heart
were no
failure,
signs of heart failure or
heart
high flow
failure,
situation.
recurrent respiratory tract infection.
Okay.
Yes,
So just
ma'am.
one thing. Can
Yes, ma'am.
TOF have CHF, heart failure? A very favorite question for everyone. Whoever
Uh,
presents TOF, this question has to be asked. This
it's
is never
not
and
there,
never
ma'am.
missed. Now, this is not there. But when can TOF have CHF or heart failure?
TOF can have
Just enumerate.
CHF, um, like if there is, ma'am, arrhythmias associated with that, of, or if there is.
So we can divide it into two parts. First is, when can any child have heart failure? If the child is completely normal also,
Yes, ma'am.
but still the child can present with heart failure.
Yes,
In
ma'am.
your pediatrics, you must have seen that the child was completely normal, but
Yes,
suddenly
ma'am.
present to emergency with heart failure.
Yes,
The
ma'am.
heart is normal structurally.
Yes, ma'am.
Then
Uh,
could be,
Anemia.
yes, severe anemia.
Yes.
So in
Yes,
severe
ma'am.
anemia in a normal child and just
Yes, ma'am.
anemia in
Yes, ma'am.
TOF, because already the oxygen demand is so high in
Yes, ma'am.
cyanotic patients. So if
Yes,
anemia
ma'am.
is there, even 8 9 hemoglobin, then the TOF can present with heart failure because of severe anemia.
Yes, ma'am.
Other cause,
Yes, ma'am. Um, Other
you've just written here
cause,
also,
no.
infective endocarditis.
Infective endocarditis. Yes, ma'am.
That can also cause because it can damage the valve, whatever
Yes,
valves
ma'am.
in this IE is there, which can lead to
Yes,
severe
ma'am.
regurgitation, can cause failure. So these are the two general
Yes, ma'am.
things. Now, what in
Mm-hmm.
TOF can lead to heart failure? Supposedly, I'm saying the diagnosis is TOF only with no
Mm-hmm.
accessory things. Hemoglobin is all right, BP is all right, no fever, no IE. Still, the TOF is having CHF. If you know, if anyone else know, just type it.
Regurgitation.
No. Okay.
Arrhythmias, ma'am.
No, not anemias.
Um,
Okay, so we'll take the
Systemic
questions later on.
hypertension.
So that is already ruled out. Okay, I'll tell this later on.
Yes, ma'am.
Right? But this is an important thing. Why
Yes,
TOF
ma'am.
will have CHF? I'm saying the diagnosis is TOF only, but the child is in
Yes.
CHF. So what is the reason and what is this term called? Okay, I'll tell later
Yes,
on.
ma'am.
Okay, we'll move
Yes,
forward.
ma'am. So my differential diagnosis is a cyanotic heart disease with decreased pulmonary blood flow, probably
Okay.
tetralogy of Fallon.
So see, by this history only, you have made a diagnosis of TOF. That's why this
Yes,
history is
ma'am.
so important, right? Each and
Yes,
every
ma'am.
point is important. Okay.
Yes, ma'am.
Now, moving forward. Now
So
you're just
general
confirming
physical.
your findings that whether whatever you have asked and whatever the parents have told you, is it correct or not?
Yes,
Right?
ma'am.
So you're just collaborating with this. Okay.
Yes,
So
ma'am.
examination.
Uh, General physical examination. Child is alert, active, and conscious. Anthropometry. Weight for age is between -1 standard deviation to -2 standard deviation. Mild underweight. Height for age is
Mild,
between
mild, and height for age you told, na? Okay,
weight
weight for
for
age.
age, ma'am.
Weight for age.
Yes,
Okay,
ma'am.
mild underweight, right?
Height for age is -1 standard deviation to -2 standard deviation. Mild stunting. Head
Hmm.
circumference for age is within normal limit.
Okay. So which classification do you do for this?
WHO classification,
WHO
ma'am.
classification. Before 5 years of age,
Yes, ma'am.
WHO classification. According to WHO
Yes, ma'am.
classification, child lies in, you have to tell which malnutrition, right?
Moderate, moderate malnutrition, ma'am.
You have to see this, that in which classification it is fitting, mild or
Yes, ma'am.
moderate. Okay. And the head circumference is normal for the age, 46.
Yes, ma'am.
Okay. Next.
Vitals.
Hmm.
Temperature is 99.4 degree Fahrenheit.
Child is
Pulse rate
febrile.
was
Child is febrile
A,
right
A
now.
febrile, ma'am. A febrile,
99.4.
ma'am.
It is
A febrile, ma'am.
99.4. The temperature you're saying is high,
Mild.
99.4. So
Mild.
this is due to heat. You must have taken
Yes,
this
ma'am.
history in daytime. The child has just come to OPD with heat. So,
Yes,
okay,
ma'am.
99. I'm just assuming this.
Um,
The child is not infected. Okay.
yes, ma'am.
Next.
Pulse rate is 116 and
Hmm.
respiratory rate is 32.
You have to
If
describe in heart
pulse rate is
disease,
100,
pulse is very, very important. And you have not
yes, ma'am.
written all the points.
Yes, ma'am. Pulse rate is 116 beats per minute, which is regular, normal, volume, and character.
There are 6, 7 points in pulse. You have to read about this. No
Yes,
radio
ma'am.
radial, no radiofemoral delay.
Yes, ma'am.
Everything you have to write, right? And
Yes,
you have
ma'am.
to
Yes,
examine
ma'am.
also. This is important, especially in
Yes,
valvular heart
ma'am.
disease.
Yes, ma'am.
Okay.
Yes, ma'am. Respiratory rate was 32 beats per minute, and cycle
Huh.
SpO2 was
So these
84%
all
on.
things has to. I'm just correcting so that you know how to present later on also.
Yes, ma'am.
In respiratory rate, when you say 32, you have to say thoracoabdominal or abdominothoracic. Right? Temperature
Yes,
also
ma'am. This is.
axillary or wherever you have taken.
Yes,
Pulse
ma'am.
rate in which artery you have taken. Respiratory rate how. So all this you
Yes,
have to
ma'am.
describe along with this.
Yes, ma'am.
Hmm.
And
Saturation.
science.
Sorry, saturation.
So,
Very important.
saturation is 84 percentage on room air.
It's so the child is cyanotic 84. So what do
Yes,
you
ma'am.
think that the parents can notice how much saturation then that the parents can say that the child is cyanotic or not cyanotic? At what saturation the parents can actually see cyanosis
Uh,
visually?
below six,
Hmm?
below 80,
This is
80
just
percent
guesswork.
is.
So it's 85. So below
Okay.
85, we can see the cyanosis by naked eyes, but above 85, it is very difficult to say,
Yes,
right?
ma'am.
So right now it's 84%. It's good. The parents have noted. The blood pressure is this again you have not completed. 90 by
Sorry,
60
ma'am.
mm of Hg
MMS. Yes,
on
ma'am.
right arm. Then you have to write about lower limb. Why is it important to take both the blood pressure in upper and lower?
Uh, so that both there shouldn't be any delay.
Why delay is there in heart disease? Which heart disease will have delay?
Uh, Patent
So it
ductus
is no,
arteriosus.
no, it is coarctation. In
Coarctation.
severe coarctation, the upper limb and lower limb BP will be different. Upper limb will be high, lower limb will be low because of the
Yes, ma'am.
coarctation in descending
Yes,
aorta,
ma'am.
right? So always and always in any heart disease or especially in CHD, you have to take both the blood pressures, upper limb blood pressure and
Yes, ma'am.
lower limb, both,
Yes, ma'am.
right?
Yes, ma'am.
That is the thing. Okay, moving forward.
Central cyanosis was noted.
So cyanosis,
Clubbing
you have
was
to tell
present.
central cyanosis. Now you have
Yes, ma'am.
committed that it is central. So what
Yes,
are the
ma'am.
sites in which do you see central cyanosis? Just
Lips,
enumerate.
tongue, mucous membrane.
Hmm. Okay.
Yes,
Because
ma'am.
fingers are both. Then second
Yes, ma'am.
point.
Clubbing was present. Grade 3
Okay.
clubbing. Uh, Present in all the fingers and
Huh.
limbs. Pan digital.
So always you tell that it is a pan digital clubbing present in both
Yes,
upper
ma'am.
limb and lower limb in all the limbs. Can there be a
Yes, ma'am.
unilateral clubbing?
Uh,
Only one finger is having clubbing. Rest nine are
yes, ma'am.
fine. Okay. Just trauma.
Yes, ma'am.
Trauma can
Okay.
cause this. Otherwise,
Okay.
we'll have clubbing in all the fingers. Right.
Yes, ma'am.
Okay.
Yes,
Next.
ma'am. No pallor,
Hmm.
no icterus, no edema.
And sixth, we have six signs. Where is the sixth sign? No.
Sorry, ma'am, there was no lymphadenopathy.
You have to write it down this also, no lymphnopathy. Now, important question. How do you
Yes,
see
ma'am.
pallor in a cyanotic heart disease? Because the this bulbar conjunctiva,
Yes, ma'am.
the palpebral conjunctiva will be
Uh,
suffused.
yes, ma'am.
So where do you see pallor
Nail
in a
beds.
cyanotic heart disease? Nail
Nail
beds will have
beds.
cyanosis.
Okay.
They'll be blue.
In the palm can be seen,
Palm,
or
palm
tongue,
crease. So palm
palm
crease. Tongue
crease
will
is.
also be blue. So
Okay,
always in a
ma'am.
cyanotic heart disease, palm creases is seen, and if the crease is fainter than the rest of the hand, then
Yes,
pallor
ma'am.
is present. Probably pallor is
Yes, ma'am.
present. Okay, so if the
Yes,
palm
ma'am.
crease, normally our palm creases are darker than the rest of the
Yes, ma'am.
color of hand. But if the palm creases are paler or lighter as compared to the rest of the hand, then that means pallor is there in a cyanotic heart disease.
Yes,
Right?
ma'am.
Next.
Head to toe examination. There was no dysmorphic feature.
Okay. So
Eye
you don't have to explain.
interpupillary.
You don't have to explain. We'll move forward. But you're just saying that there is no dysmorphic features, which is very important because
Yes,
dysmorphism
ma'am.
and genetic disease are very common in heart disease.
Yes,
Especially, I
ma'am.
just told you that like Downs,
Down
DiGeorge,
syndrome,
Alagille,
George.
all this will have
Yes,
dysmorphic features. So it is important to rule
yes,
out
ma'am.
that the child is not having any dysmorphic features.
Yes, ma'am.
Okay. Moving forward.
Eyes interpupillary distance
No,
is
no.
normal.
Moving forward means
Okay.
next slide because
Okay.
this is normal.
Okay, ma'am.
Hmm.
Yes, ma'am.
Okay.
Systemic examination, serious
Hmm.
examination.
Now, this is very
Uh,
important. The systemic examination of cardiovascular system. How do you do
yes,
it?
ma'am.
It's not about
Yes, ma'am.
always, if you hear murmur, you know everything. If you don't know the murmur, you don't know about the examination. The rest things are also important. You can get a clue about by them also. So that's why
Yes, ma'am.
you have to move one by one. So first of all,
Yes,
and
ma'am.
very important is inspection.
Yes, ma'am.
Mhm.
Precordium appears normal.
Okay.
Normal shape and symmetry of the chest. No
Mhm.
visible precordial bulge.
Mhm.
Tracheal position was central. No visible cardiac pulsation. No engorged veins.
Okay. So
Yes,
if
ma'am.
there was precordial bulge, what does that mean? That there
That's
is.
usually present in cardiomegaly, but
Yes.
here,
So you have ruled out cardiomegaly too by this, just by
yes, ma'am.
inspecting, just by looking at the chest without touching the
Yes,
child.
ma'am.
You rule out that
Yes,
there's
ma'am.
no bulge, there's no asymmetry, everything looks
Yes, ma'am.
normal just by looking
Yes, ma'am.
visually.
Yes, ma'am.
So
Yes, ma'am.
there's no CHF. Okay. Then
Then
next,
no
next slide. Palpation. Very important palpation.
palpation. Yes, ma'am. Apex beat
Mhm.
is palpable in left fourth intercostal space,
This is also not
and no
complete in,
palpable thrill
you have to complete this in left four intercostal space where just medial, just lateral, axillary line,
in the mid
mid-sternal line, which
clavicular,
one? Clavicular line,
in the
which one?
mid clavicular line, ma'am.
Yes, so you always and always have to complete it. That apex beat
Yes,
is
ma'am.
palpable in the left fourth
Yes, ma'am.
intercostal space in the
Yes,
mid-clavicular
ma'am.
line. Which type of apex is it? So do you know what are the types
Right.
of apex beat?
Uh, no,
Whether
ma'am.
it is whether it is LB type or RV type. Now,
RV type.
so how do you differentiate it? That LV type of apex is very sharp,
Yes,
right?
ma'am.
Very sharp. You
Okay.
can see and you can localize it in one space only. If you put your,
Okay, ma'am.
how do you palpate apex beat? First of all, you have to keep your whole hand on the side of the
Yes,
chest,
ma'am.
and then you'll feel
Yes,
the
ma'am.
pulsation, and then you pinpoint it that here is the apex beat, right? So
Okay,
if you
ma'am.
can do
Yes,
this very
ma'am.
sharply, that this is the point where apex beat is coming, so
Yes,
that is
ma'am.
LV type of apex. But if you get a
Yes, ma'am.
diffuse type of apex, the pulsations are present in a diffuse area, in a larger area, like in two
Yes, ma'am.
spaces, and also you're
Yes, ma'am.
getting epigastric pulsations, then that means it is RV type of apex. So by doing
Okay,
it,
ma'am.
you'll differentiate it whether it is a very localized apex or a diffuse apex. So if it is
Yes,
diffuse
ma'am.
apex, it is RV. Localized, it is
Yes, ma'am.
LV. So what do you
Yes,
think
ma'am.
that in this patient, which type of apex will be there? LV or
Diffuse
RV?
type of
Diffuse, RV
RV
type of
type.
apex. So you
Yes,
have to
ma'am.
describe that apex beat is present in this space, in this line, and it is most probably RV type of apex with epigastric pulsations. Right?
Yes, ma'am.
Next point you have written, no palpable thrill is there.
Sure.
Okay.
Yes,
And
ma'am.
one very important point which we see in palpation and it is not present in this patient is
Um,
whenever you tell about palpation, you have to do one more thing, and
record
that is parasternal
confirmation of the.
heave.
Oh,
Parasternal
yes, ma'am.
heave. That is very,
Yes,
very
ma'am.
important. So one
Yes, ma'am.
very important differential in this case is pulmonary stenosis with intact septum. Now just understand the physiology.
Yes,
If
ma'am.
you're saying that it is PS with VSD, then all
Yes,
the
ma'am.
blood which is coming into RNRV and it is not going through the pulmonary artery is shunting through VSD into LV in a single systole, right?
Yes, ma'am.
The heart is
Yes,
beating
ma'am.
together, RV and LV. So whenever whatever the blood is coming from into RV, just in systole, it gives all this blood in one beat in systole through VSD into LV and then LV to aorta. So nothing is
Yes,
there
ma'am.
in RV. So RV is not hypertrophied that much. Although we say that in four things of TOF that RVH is there, but that is not severe hypertrophy because the VSD is there.
Concentric. Yes,
VSD is there, it is not concentric. But if
yes,
it
ma'am.
is intact septum, just imagine if the
Yes, ma'am.
septum is intact, there's no VSD. All the blood which is coming to right side has to go through pulmonary artery. There's no other
Yes,
option.
ma'am.
It cannot go through
Mm.
VSD. So
Yes, ma'am.
eventually the RV will be hypertrophied. So that hypertrophied RV you'll palpate as heave. So how do you
Yes, ma'am.
palpate heave? Through your ulnar border.
Ulnar
You
border.
keep your
Yes.
ulnar border on the parasternal area and you just feel the heaving pulsations of RV. So that is parasternal heave.
Yes,
That also you grade
yes,
it.
ma'am.
There are three grades of RV heave. So never
Yes, ma'am.
and never there'll be parasternal heave in a patient of TOF because
Yes,
VSD is
ma'am.
there. So
Yes,
again,
ma'am.
the same question which I was asking. Which type of TOF will have a parasternal heave?
Mm.
If anyone knows, just can type in the box. I'll see at the end or I'll tell if there are no answers. So which type of TOF will have
Mm.
parasternal heave? Which type of TOF will have CHF? Which type of TOF will have palpable thrill? The questions to all this is one answer.
If
So
there is increased
no.
right
It's nothing.
ventricular
We'll
effect.
move forward.
Yes, ma'am. No
I'll tell the
palpable
answer
thrill
at
was present.
okay. And no
Yes,
parasternal
ma'am.
heave is there, right?
Yes, ma'am.
Next,
Auscultation.
auscultation, okay.
S1 is normal. S2, A2, P2 heard. P2 was soft.
Okay.
There was
So
grade
hmm, the very
3 or
important point in S2, always and always there are two components of S2,
yes,
A2
ma'am.
and
A2,
P2, which
P2.
is closure of aortic valve and closure of pulmonary valve. Which
Pulmonary
component
valve.
is earlier, aortic or pulmonary?
IoT.
Aortic. So A2 comes before P2 because of hangout interval. The
Yes,
hangout
ma'am.
interval of aortic valve is lesser as compared to pulmonary valve. So
Yes,
A2
ma'am.
comes earlier as compared to P2. So you have to get the habit of listening to two components of S2, right? Now P2 is
Yes, ma'am.
soft. I know these findings you have confirmed by your senior. That's why you're knowing that P2 is soft. Otherwise, it's very difficult to say. You can
Yes,
tell
ma'am.
that it will be single S2 also. Even if you're not
Okay.
hearing the second sound, you can say single S2. I'm just
Yes,
hearing
ma'am.
one sound in single S2. Now, what are the DTs of single S2?
Uh,
That means either A2 is absent or P2 is absent. What do you think? Which can be absent? A2 or P2?
uh,
In
here,
TOF,
P2.
P2 will be absent. Because of severe
Yes, ma'am.
stenosis, the
Severe
pulmonary valve is
stenosis.
not getting closed
Yes,
completely.
ma'am.
That's why you're not
Yes,
hearing any
ma'am.
sound. A2 is
Yes,
absent
ma'am.
means severe AS or atresias.
Yes,
With severe
ma'am.
AS or
Pulmonary.
atresia, the child won't be alive without any
Yes, ma'am.
surgeries, right? So always
Yes,
P2
ma'am.
is absent whenever you are saying that
Yes,
single
ma'am.
S2 is there. One more thing, whenever there's single S2,
Pulmonary atresia.
that is done. Just a
Um,
question again, not for you, but for other fellows. In TGAs, because the arteries are anterior-posterior. In TGA, aorta is anterior and pulmonary artery is posterior. That's why you will hear
yes,
just
ma'am.
single S2.
Yes, ma'am.
Okay, so TGA also single S2 and TOF also single S2. If you can hear
Yes,
it
ma'am.
very correctly, then P2s can be soft or single S2. Right. Now, how do you
Yes, ma'am.
describe the murmur here?
A murmur was grade 3 or 5. Ejection systolic murmur, best heard in the left upper sternal border, radiating to both infraclavicular region and the back. It is
Okay.
harsh and high pitched murmur.
Okay. So this is grade 3 by 6. So there are 6 grades of murmur, right? Whenever you hear
Uh,
this thrill, it is grade 4. So
yes,
you're
ma'am.
not hearing any thrill. There's no thrill. So it was
Yes,
grade 3
ma'am.
by 6 murmur
Yes, ma'am.
present at the left upper parasternal border, which is radiating to
Yes,
back.
ma'am.
And it is harsh type of murmur, high pitched. So
Yes,
by
ma'am.
this
Yes, ma'am.
murmur, what do you interpret? How
Um,
how severe is PS? How much blood is going through pulmonary
um,
artery? PS is always severe in TOF, but how much blood
yes,
is
ma'am.
going? How tight is this pulmonary
Decreased,
stenosis?
decreased blood. Um,
It is decreased. That is well understood. That's why it is TOF.
yes, ma'am.
But how much?
Yes,
You
ma'am.
say very severe TOF or it is not so severe.
Not so
So
severe of ma'am.
how do you say this?
Because if grade 4 and
No, this is
5
grade
would have
3.
been.
This is grade
Yes,
3. In
ma'am.
grade 3, why is it not very severe? The blood is still going in pulmonary arteries.
Um,
So always remember that Murmur is inversely proportional to
To
intensity.
the stenosis. Yes, ma'am.
To intensity of murmur is inversely proportional to the stenosis.
Stenosis. Yes, ma'am.
Okay. If you are getting very harsh, high pitched murmur, right? If the
Less
grade is
stenosis.
high, so stenosis is less because blood is
Yes,
still
ma'am.
going into pulmonary artery. If you're not
Yes,
getting
ma'am.
any murmur, the child is
Yes, ma'am.
severely blue. You're not getting any murmur, very faint murmur. That is severe stenosis. So the intensity of murmur is inversely proportional to pulmonary stenosis
Stenosis.
or the amount of blood going through pulmonary artery. If you're getting a good murmur, that means the blood is still going. That's why the saturation is 84. If
Yes,
there
ma'am.
was so severe stenosis that no blood is going through pulmonary artery, the saturation would have been 70, 75. So you can
Yes, ma'am.
collaborate with this that these two things are there, the stenosis and murmur, right? Now, again, one
Yes, ma'am.
important point you have written, there's no S3, S4. What does this suggest?
Uh, there was no aortic,
Mm, mm,
sorry,
mm, mm, mm,
atrium. S3 is mainly because of
mm.
atrium.
Because of increased flow. Like in
Yes, ma'am.
VSD, you
Volume
get S3,
overload.
S4, volume overload.
Yes,
So
ma'am.
in TOF, there is no
Yes,
volume
ma'am.
overload. You've already told there's no
Yes, ma'am.
CHF. Why there's no
Yes, ma'am.
CHF in TOF?
Because of large shunt VSD,
Hmm.
ma'am. Ventricular
Hmm. So
septal
all the blood
defect.
which is coming to right ventricle,
Right
in
ventricle will
systole,
be
it is
flow to the
ejecting into
left.
in
Uh,
through LV
right to
into
left.
aorta. So there is no
Yes, ma'am.
CHF. There's no stasis of blood, right?
Yes,
So
ma'am.
again and again,
Yes,
you are
ma'am.
telling by history also that there's no CHF, by examination also there's
Yes,
no
ma'am.
CHF, no S3, S4. So you are just incorporating this fact that this is a cyanotic heart disease with decreased flow with no CHF.
Yes, ma'am. Yes, ma'am.
Next, moving forward.
Other systemic examination.
Hmm.
RS, respiratory system, bilateral air entry present equally. Chest was
Hmm.
clear, no added
Hmm.
sound was present.
Hmm.
CNS, alert, active, no focal neurological deficit. Per
Hmm.
abdomen, soft, non-tender, and no hepatosplenomegaly was present, and bowel sounds were heard.
Hmm. So very important, whenever you do any examination, always remember to include other systemic examination also. If you're doing
Yes,
cardio,
ma'am.
you have to rule out other systems also because there may be symptoms or there may be signs in other systems. Like in this case, in TOF, CNS could be affected if there was any
Yes,
focal
ma'am.
neurological deficit, or in
Yes,
abdomen,
ma'am.
you have to see hepatosplenomegaly. There's no
Yes,
CHF, so
ma'am.
liver is not enlarged. No spleen
Yes,
is
ma'am.
there. The child is not dysmorphic. There's no HS megaly, right? So you have to rule out this also. So always and always, it's
Yes,
not
ma'am.
that you have just made your mind that this is a cardiac case. You won't be doing other system examination. You have to do all the system examination. That is important.
Yes, ma'am.
Okay, moving
Yes, ma'am.
forward. So you have done your
So,
history, you have done your examination. Now you're coming to differentials. So what is your
yes, ma'am.
most probable differential by all the history you
So,
have taken by the examination?
yes, ma'am. My most probable differential is tetralogy of Fallon, ma'am.
Acha, you can say that it is TOF without doing echo. Or you will say something else. TOF, it is TOF.
It's a cyanotic heart disease with decreased pulmonary blood flow, uh, suggestive of TOF.
Hmm. I'll take all the questions at the end. You can just
Yes,
type in
ma'am.
and then I'll take all the questions. So it will be TOF physiology, right? It will be TOF
Okay,
physiology. You
ma'am.
cannot say it is TOF. So the
Yes,
next
ma'am.
question is what all comes in TOF physiology? So what is actually TOF physiology? Because by history examination, you can just say it is TOF like physiology. It's not actually TOF. So
Yes,
what are the
ma'am.
6 points or the 6 congenital heart
Um,
disease which comes in TOF physiology? You remember them?
uh, any cyanotic heart disease with decreased pulmonary blood flow, that
So
is.
it is VSD PS physiology. So in any CCHD, whenever
Yes, ma'am.
there is VSD PS with ventricular septal defect, there is PS, we call it as TOF physiology. So the classical
Yes,
one is TOF itself. The second is DORV, double outward route ventricle with VSD with PS.
yes,
Then
ma'am.
TGA with VSD PS. Even TGA can have this TOF like physiology.
Okay.
Okay, so but if it is
Yes,
having
ma'am.
PS, pulmonary stenosis, not the usual
Yes,
TGA
ma'am.
with VSD or intact septum, TGA with VSD with PS,
Yes,
right?
ma'am.
Or
Yes,
CCTJ
ma'am.
with VSD PS, or any single
Yes,
ventricle,
ma'am.
with VSD PS. So like any heart disease in which there is VSD and PS, and
Yes, ma'am.
along with this other things are also there, so that is TOF physiology. So why is it important?
Mm.
Because any TOF physiology can have similar symptoms and signs. The child can have TET spells, the child will have the same similar examination, although subtle difference will be there, but similar findings. So you cannot say at the end of history examination this is TOF, maybe it is DORV VSDPS, right? So you have to say
Yes,
it
ma'am.
is TOF physiology. You have to tell
Physiology.
the TOF physiology, right? So one is TOF
Yes, ma'am.
physiology. Other than
Yes,
this,
ma'am.
you have written pulmonary
Uh,
atresia with VSD.
yeah.
So pulmonary
Yes, ma'am.
atresia with VSD will have this murmur, this ejection systolic murmur.
No, ma'am.
The pulmonary valve is atretic. It is not opening.
Yes, ma'am.
It is not
Yes,
formed.
ma'am. Yes,
Then the
ma'am.
blood is not going through
So
pulmonary
that
artery.
can be.
So what murmur will you have in pulmonary atresia with VSD?
Flow.
Collaterals will be formed. Collaterals. So there'll be continuous murmur of
Continuous murmur.
collaterals. Of
Yes, ma'am.
collaterals. Okay. So pulmonary atresia with VSD, not the similar murmur. Okay. Next
Yes,
thing you
ma'am.
have written tricuspid atresia with PS. So I told you anything VSD and PS comes in TOF physiology. So this third point
Yes,
will come
ma'am.
in TOF physiology.
Of physiology.
Okay. Fourth is Epstein's anomaly.
Epstein's
Okay. Epstein's
anomaly.
anomaly won't have this PS murmur. Right? The child
Okay, ma'am.
will be blue, but the examination findings will be different. There will won't be any spell. So this is a
Yes,
low
ma'am.
dose. Then DORB VSGPS, again I told you this comes in TOF
Of
physiology.
physiology.
Okay. So TOF physiology
Yes,
you
ma'am.
can say and then you can describe. Okay.
Yes,
So what
ma'am.
is the provisional diagnosis?
My provisional diagnosis is
So
cyanotic
one
heart
important
disease.
thing, everyone note this. How do you say that this is the provisional diagnosis? You cannot directly say that this is a TOF physiology patient. You have to write it down in points. So these are the points. I'll just see how
Yes,
she's
ma'am.
written. Okay.
So it is a cyanotic heart disease, probably tetralogy of physiology with
This you
decreased
have to tell in
pulmonary.
end. This you have to tell in end. So you have to say it is a cyanotic heart disease with decreased pulmonary blood flow. Okay.
Yes, ma'am. With right to left shunt, most likely PS with VSD,
Huh. So you don't have to
without
write this. You can
complication.
say TOF physiology.
Yes, ma'am.
TOF
Without
physiology itself means
complication,
VSDPS. Okay. Without complications.
without complication, no infective endocarditis, no congestive heart failure, no cerebral abscess or stroke, with grade 1 malnutrition and moderate stunting, with normal development without any dysmorphology.
Hmm. So how do you describe this provisional diagnosis? First of all, you have to tell that it is a cyanotic congenital heart disease. Second
Yes,
point,
ma'am.
with decreased pulmonary
Decrease
flow,
pulmonary blood flow.
decrease or increase. Third point,
Yes,
most
ma'am.
probably top physiology. Fourth point,
Yes, ma'am.
complications. In complications, add one more with normal
Yes, ma'am.
sinus rhythm, right?
Yes, ma'am.
Without any arrhythmia.
Yes,
So
ma'am.
just add
Yes,
in
ma'am.
complications with normal sinus rhythm. These 4 points.
Yes, ma'am.
Then from your general examination that there was this much grade of malnutrition and developmentally normal. These 2 points in
Yes,
the end.
ma'am.
So these are the 6 points you have to tell in provisional diagnosis. You
Yes, ma'am.
cannot tell it directly,
Yes,
it's
ma'am.
top physiology. This 6 points should be there, right?
Yes, ma'am.
Then,
Then X-ray finding.
okay.
This is
So
a.
whenever you present, you have to present history examination, X-ray, and ECG
Yes,
also,
ma'am.
if you could
Yes, ma'am.
understand this. Okay.
ECG have added me. Yes, ma'am.
Mhm.
It's a X-ray, PA
Huh.
view X-ray with the cardiac border is seen with the uh,
How do you describe
uh,
X-ray in heart disease? First of all, view.
card- cardiothoracic ratio. View is PA view with the
Mm.
uh, cardiothoracic ratio is less than 50 percentage, with apexes directed upwards, mainly because of the right ventricular hypertrophy,
So
and the
you don't have to say
pulmonary.
mainly because of this. You have to say RV type of apex.
Yes, ma'am. And the pulmonary base concave due to
Absent, huh?
uh,
You don't have to say due to.
hypoplas.
See, when you describe an X-ray, na, you just have to tell the findings. If the examiner will
Yes,
ask,
ma'am.
why is it so? Then you have to tell that this is the reason. But when you're
Yes, ma'am.
describing X-ray, just tell the points.
Yes, ma'am. And the lung appears oligemic lung field.
Hmm. But the most important point is, first of all, you tell two things in this. First, situs solitus. That means
Yes, ma'am.
liver is on the right side. Can you see this opaque
Yes,
shadow? And this gas
Yes,
bubble
ma'am.
on the left side. So stomach is
Yes,
on the
ma'am.
left,
Stomach.
river is on the right. That is normal.
Yes, ma'am.
You call it
Yes, ma'am.
situs solitus.
Solitus.
Okay. If it is
Yes,
inverted,
ma'am.
then it is situs inversus. This is solitus. So situs solitus. Secondly,
Yes, ma'am.
the apex is on the left side. It's not on the
Yes,
right
ma'am.
side. The apex, whatever apex it is, whether it is LV or RV, but it is on the left side. So it is
Yes, ma'am. Uh,
levocardia.
Livocardium.
It's
Okay,
not
ma'am.
dextrocardia, right? So these two things
Yes,
you have
ma'am.
to add in heart disease X-ray. That's
Yes, ma'am.
situs, you have to tell, and which position is the apex on,
Yes,
left
ma'am.
or right. So levocardia. So situs solitus, levocardia. Then you have to tell about cardiomegaly is there or not by CT ratio. Then which type of apex is there. The pulmonary bay,
Uh,
very important. And then
yes,
comment
ma'am.
upon the pulmonary blood flow, whether it is increased flow, decreased flow.
Yes,
In this
ma'am.
X-ray, you cannot comment much because the exposure is not good. That's
Okay,
why
ma'am.
the 4 points in X-ray, before telling that what type of X-ray is there, is rotation, inspiration, projection, exposure. So
Okay,
RIPE,
ma'am.
you have to remember, RIPE.
Yes,
Rotation,
ma'am.
inspiration, expiration,
Expression, explosion,
projection,
and
APPA, which
expose.
one, and exposure. So always
Yes,
start
ma'am.
with this, then say situs solitus, then levocardia, then CT ratio, then pulmonary bay, then pulmonary blood flow, right? So what is the
Yes, ma'am.
typical finding in this?
Boot-shaped heart. It's also
Known
called as
as
coir and sabot.
core and support heart, boot-shaped heart.
Yes,
A
ma'am.
typical X-ray of TOF, boot-shaped heart.
Yes, ma'am.
Okay. Okay. Next.
ECG finding.
Okay. CGF
Uh,
added. Good.
yes, ma'am. In ECG, usually a child will be having right axis deviation. Here,
So is it right
P
axis
way.
deviation? You know how to see right
Uh,
axis deviation?
yes, ma'am.
I don't know. You are in first year, right?
Yes, ma'am.
So it will be difficult. So, but still, if you know, it's very good. So you have to see two this one and AVF. So
Yes,
if
ma'am.
one and AVF are approaching towards each other, it is
Each
right.
other. So right axis. If it is away from each other, then it is left
So
axis.
you see one and AVF, they are approaching towards each other. There's a right axis deviation. In V1, R wave
Uh,
is tall.
yes, ma'am. So it means that right ventricular hypertrophy is there.
Hmm. And then you have to see the rhythm in two, lead to.
Lead
Every
to
P is
rhythm
followed
is
by
no.
QRS.
Yes, ma'am. Normal it is.
RR interval is normal.
Yes, ma'am.
PR interval is normal. So
Yes, ma'am.
just for you, it is that RVH is present. It is a normal sinus rhythm with
Yes,
RVH
ma'am.
with no block.
Yes, ma'am.
Okay. Okay. Moving
Yes, ma'am.
forward. Okay. So thank you. So now, according to you, it is a cyanotic heart disease with
Uh,
decreased pulmonary blood
Decreased
flow.
pulmonary blood flow,
Hmm.
probably top physiology.
Hmm. So can you just one question? Can you just interpret from all your history and examination what were the positive findings which were telling that it is tough, starting from history?
Yes, ma'am.
Just
Starting from
enumerate.
history, uh, the child had central cyanosis with
One,
TED spell, uh,
two.
episode of TED spell, and then
You have to start from cyanosis at what age? Was it cyanosis at
cyanosis.
birth?
No, ma'am.
So
Cyanosis
not
at
at birth. So one pointer
no.
towards TOF. It was not
Yes, ma'am.
at birth. So
Cyanosis
late
at 4
onset
month of age.
cyanosis, central
Late onset
cyanosis,
cyanosis.
dead
Yes,
spells.
ma'am. Yes, ma'am.
Other than this,
And had taken medication, propanolol probably 3 times.
okay.
And then on examination,
History,
on easy
history.
fatigability, on history, easy fatigability, on
Okay.
exertion, on while playing.
And your negative
Uh,
history. One very important
Negative
point.
history. There was
There was no
there was no history suggestive of increased pulmonary blood flow,
no CHF.
and there
You
was
just said there was no
no
history of
CHF,
CHF. So again, one point
and
towards the TOF. Then
no
examination.
complications of TOF
Huh,
on examination.
that is how different, but no CHF. That is
Yes, ma'am.
one pointer towards
Yes,
TOF.
ma'am.
Then
Yes,
examination.
ma'am. On examination,
What were the
uh,
pointers towards TOF?
one was central cyanosis was present, and grade 3 clubbing was present,
Hmm.
and uh, as on saturation was maintaining 84 percentage on room
Hmm.
air,
Hmm.
and on examination there was grade 3 by 6 murmur, which was
Murmur was
ejection
there.
systolic
Before
murmur.
this, RV type of apex was there,
Yes, ma'am.
right? An
And
injection systolic
yes,
murmur.
ma'am.
So you call
Yes,
this
ma'am.
as quiet precordium. That means
Yes, ma'am.
if the child was having increased pulmonary blood flow, then the
Yes,
child would
ma'am.
have been very tachypnic. There would have been retractions, like many
Yes,
findings
ma'am.
on chest. But this, the child is calm. There's no cardiomegaly, there's no retractions, no visible pulsations, nothing. Just an
Yes, ma'am.
auscultation, you'll hear an murmur. So you call a
Yes, ma'am.
TOF patient on examination as having quiet precordium. This is classical
Yes,
of
ma'am.
TOF. So quiet precordium is 1 point. So these are the pointers in which you say. Now, what do you think? How severe is this TOF?
So,
Does this require urgent
th-
surgery? Like at this
no,
age, it
ma'am.
does require. Yeah, at this age, it
Ah, yes,
requires.
ma'am.
What is the age of surgery?
Yes. Usually it is 6 to 12 months of age if the child is stable. If
So
the
this
child
is
is
1.5 years.
symptomatical,
So at this age, so it is required. But
yes,
supposedly
ma'am.
the child has come to you and given you history at 6 months with 84
Okay, ma'am.
saturation with the
So
similar
if the
history.
child is with the
So
child is
what are the
stable,
pointers for severity?
so symptomatic, like severity, if there is any CNS complication.
Not severe CNS complication. If the child is having frequent spells, 1 point, that is a
Sinuses,
severe
yes,
TOF.
ma'am.
Then
Yes.
by
Or
examination, 1 point, I told you that this is very important point which tells about the severity of TOF.
grade
The
of murmur.
Yes, the grade of murmur. The
Yes,
grade
ma'am.
was 3 by
Yes, ma'am.
6. That means it's not
Yes,
very
ma'am.
severe. The pulmonary blood flow is still going through pulmonary artery. The murmur
Yes,
was
ma'am.
very short. And age of presentation. Earlier, the age of
Yes.
presentation, more severe is TOF. Right? So
And
the
if
now we'll move on to management. This is the last part we are covering. So
yes,
management.
ma'am.
So what is the medical management of TOF?
Medical management of TOF is mainly propranolol, beta
Hmm.
blockers
How
we
does
give.
this propranolol act?
So basically, it blocks the beta one adrenergic receptor. So
Hmm.
that will decrease the catecholamine release. So that
Hmm.
will further cause decrease in infundibular spasm,
Hmm.
and contractility of the heart also will be decreased.
Hmm.
So
So very
the
good. So these are the mechanism of propranolol. How does propranolol act? So
yes,
it's actually it
yes,
decreases
ma'am.
the infundibular spasm, which is
Yes, ma'am.
characteristic of the spells
Yes,
because of
ma'am.
its beta blockage actor. Okay, so propranolol. What is the dose of propranolol? You know about this?
Usually we give 1 to 4 milligram per kg per
So
day,
usually
ma'am.
1 milligram. You remember 1 milligram per kg per dose.
Dose.
Hmm.
Yes, ma'am.
In how many? How frequent?
We give thrice daily or
TDS. You give TDS.
yes, ma'am.
Okay.
Yes, ma'am.
Apart from this, you give.
Uh,
You have already told. Apart from
we give
propranolol, you also give. You told earlier. Propranolol and
iron medication.
iron.
Yeah,
Huh.
iron medication. Yeah, ma'am.
Okay, okay.
And
I
in
hope I'm not
refractory
overloading
cases,
you
we
with
can give
questions.
phenylephrine. Oh, ma'am.
Okay, so iron also we give. Why iron is required? Hemoglobin is already 14, 15 in a cyanotic
Usually
patients.
in
If you
iron
do CBC,
deficiency anemia, if there is anemia,
why anemia? The hemoglobin is 14, 15.
because that can masked by secondary polycythemia. The
Okay,
child can have anemia, but
why?
no pallor will be visible because it is
Mm-hmm.
masked by secondary polycythemia.
But why do you give iron in 14, 15?
And
Why? No, the reason is still not clear. Because
if iron
the
deficiency
oxygen
anemia,
carrying capacity is still low in a
RBCs are
cyanotic patient. Yes, the RBCs are depleted of iron. The oxygen carrying
oxygen
capacity
carrying
is low. So
capacities.
for this, you have to give iron, right? Even if the hemoglobin is very
Hello,
high, even if the hemoglobin is very high, you have to give iron because the oxygen carrying capacity is low.
hello,
You are audible. You are audible. Hello, you are
hello.
audible. Yes, you are audible, Ananya. Hello.
Hello, ma'am.
Yes. Am I audible to you?
Yes, ma'am.
Okay. Hmm. So continue. Continue.
Yes, ma'am.
Huh. So
Theory
iron
part,
is
ma'am.
also given. Huh.
There are
Iron is no, no, theory is not
yes, ma'am.
required. We have already covered all the theory. Just the management part. So
Okay, ma'am.
propanol and iron. Next is very
Yes,
important
ma'am.
question. How do you
Yes, ma'am.
manage the TET spells?
TED spell is mainly managed. First is calming the child when
Hmm.
the incident happens, and to the maneuver either squatting or
Squatting.
jack
The
and knife
child is having
position.
spell. The child you will do squatting maneuver.
So, knee chest position.
Knee chest position. If the child is having the
Uh,
spell, there's a
Knee
small
chest
baby.
position.
Hmm. How do you calm the child?
Administer oxygen. Child
Have you-
by giving morphine.
Hmm.
It's usually
Then there was
hello.
acidosis. Huh.
Giving
Then there is
morphine, ma'am.
acidosis. Okay. For
If
acidosis.
acidosis, this is correct the acidosis by sodium bicarbonate, which we
Okay. Then this infundibular
equivalence
spasm.
per
You
kg.
correct? Infundibular spasm.
And then give IV fluid
Hmm.
by giving beta blocker. But if
Okay.
any refractory cases, we give phenelphine also, which is an
Okay.
alpha 1 selective.
So what does phenylephrine do? This increases the
And yes, ma'am.
this is increases the SVR, right? So that the right to left shunt is
Systemic
decreased.
vascular resistant, it
Yes.
increases, ma'am.
Yes. Yes.
Yes,
Okay.
ma'am.
Suppose
Increased.
everything is not working. You have done everything. The child is still in spell. Then next thing is
Yes, ma'am.
even after intubation, you have given
You
ketamine,
give next
phenylephrine,
is
everything.
sedate.
You have done everything. Still, the child is having spells. You
Yes,
can
ma'am.
see the saturation is very low.
Then surgery.
Which surgery?
Uh,
Which surgery do you do in refractory spells?
and definitely surgery we do is stenosis repair with patch.
No, 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 no. I'm asking
Uh,
the child is having refractory
no.
spells, right? The spells are not improving. Will you do this whole surgery
Yes, ma'am. Yes,
with
ma'am.
VSD closure and patch? No. So urgent surgery, you need something
Or
urgent. In this, the
palliative
bypass is
surgery,
not
ma'am.
required. So that is BT shunt. So just remember, if nothing is working, all the medical management is not
We
working,
put
then you do BT shunt.
yes,
Okay?
ma'am. BT shunt we can.
Yes,
Yes,
so
ma'am.
BT shunt is there.
Yes, ma'am.
Otherwise, the definitive management is
Yes, ma'am.
what is the definitive management?
Definitive treatment is stenosis repair with patch closure, ma'am.
So VSD closure and this pulmonary artery, the stenosis that you repair by either patch or you dilate it.
Yes, ma'am.
Okay?
Yes, ma'am.
So I think we
Yes,
have
ma'am.
covered all the things. Just one, two
Yes,
questions. And the one question which I was asking initially, nobody has answered, I guess. So that also I'll cover. Okay. So that is, first of all, what is the one abnormality in TOF, which you say that this is the most important thing, by which all the four things have started. So that is anterior deviation of conal septum.
anterior displacement of the
Conal septum, which
anterior
causes
division of
PS.
yes,
See,
ma'am.
pulmonary arteries are anterior, aorta is posterior. So when this conal septum deviates anteriorly, so pulmonary
Yes,
stenosis
ma'am.
will be there. Infundibular stenosis, pulmonary stenosis. Less of the blood will go through RVOT. So this is the most
Yes,
important
ma'am.
point. Only due to this, everything else is there. Due to
Yes, ma'am.
PS and VSD, the blood is going from right to left. Cyanosis is there. RVH is there. Overriding is there. Right? So it is anterior division of
Yes,
conal
ma'am.
septum.
Yes, ma'am.
Okay. Now the one star
Yes, ma'am.
question which I was asking, I think nobody has answered. I'll answer their question also, whatever they've written. So
Um,
that is TOF with restricted VSD. If the VSD is small, see in TOF the VSD is very large. So whatever blood is coming to right, it
so,
is everything is going to LV. But if the VSD is small, then
hello.
there will be TOF with CHF. CHF means the blood is retaining inside the heart.
Left to right shunt and patient
Yes.
can present.
No, not left to right. Just listen.
Pink top.
No, 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 no. Just
Yes.
listen first. If the VSD is very small, then whatever blood is coming to right side, that is not going to the left side. Not complete because the VSD is small. See, the egress is small. So the blood will be retained in the right ventricle. So this will
Yes,
cause
ma'am.
CHF. So causes of TOF with CHF is also TOF with restricted VSD. Or one more question I asked, TOF with this heave, parasternal heave. Otherwise in TOF there is no parasternal heave. But if heave is there, that means RV is very much hypertrophied. Why?
Yes,
Because
ma'am.
VSD is small, restricted VSD. So we call this variant as Hoffman
Yes, ma'am.
variant, right? HOFFMAN,
Oh,
Hoffman variant. So Hoffman variant means TOF with restricted VSD.
Hoffman Bay. Okay, ma'am.
Okay, so the causes of TOF with CHF or with parasternal heave or with thrill, the answer is TOF with restricted VSD, which is also known as Hoffman variant,
Yes,
right?
ma'am.
So I think we have covered
Yes.
everything. So Ananya, you have presented it very well. You're just first year, but you know how to approach a case of cyanotic heart disease or any heart disease. Otherwise, also, all the PGs or anyone is
Thank
most
you.
welcome. In Gangaram, we have a lot of cases, we have a lot of patients. You can see, you can examine them, you have taken history, then we can discuss there also. You'll just know about how to approach heart disease patients, right? See, you're not an echo, but before echo also, by proper history and examination and other things like X-ray and ECG, you have come to a diagnosis. So you can start propranolol. You can tell the patient that you can wait till this time.
Yes, ma'am.
You can tell them that the surgery will be
Yes.
done. So all these things can be done before echo. That's why clinical history and examination is very important. You have to do in every patient, right? You have to spend time with patient attendance. You have to see the patient. So this is important.
Yes,
Now
ma'am.
I'll just take all the queries.
Yes, ma'am.
The first question is, Ananya, you have to answer, right? If you don't answer, then I'll answer. So first is why not before six
Yes, ma'am.
months? So we have already discussed why the spells doesn't occur before 6 months.
I can't hear.
Not audible?
Uh,
Audible?
Hello.
Hello, audible?
Yes, ma'am.
Huh.
Hello, ma'am.
Why
Yeah, ma'am.
spell
Before
doesn't?
6 months, it's not because
Mhm,
one is patent ductus arteriosus will be there that will cause
mhm.
the oxygenated blood pass through the vessels and
Okay. Second?
hemoglobin
Second?
will be
Huh.
there.
Second point?
Uh, Second point, fetal hemoglobin, ma'am.
Hmm. So oxygen requirement is not very
Hello.
high before. Huh. Oxygen requirement is not very high before 6 months, right? Also, PDA will be there,
Yes, ma'am.
and
Yes,
fetal
ma'am.
hemoglobin will be there,
Yes, ma'am.
right? That's why
Yes,
cyanosis.
ma'am.
This is not about spell. This is cyanosis. So cyanosis is not noted before, not exactly 6 months, but not before 2 to 3 months. Only after 2 to 3 months, when the oxygen demand increases, then you'll note that cyanosis is there. But in TGA, since the arteries are switched, all the oxygenated and deoxygenated blood is not getting mixed. If it is TGA with intact septum, you'll note that cyanosis will be at birth. Okay, so you have to take this very important
Yes,
history
ma'am.
that cyanosis is at birth or after birth. Second question, reason of why TET
Yes,
spell
ma'am.
beyond 2 years of age is not there. So why TET spell not beyond 2 years of age? Because the child
The
has
main thing
already
is
hmm, just tell,
himself will
acquire
get
certain
used to with
positions.
the
Huh. The child will himself
himself
acquire
or
certain
herself will get used
positions,
to with the
huh,
yeah
which is known as
um,
squatting equivalents. So child will acquire certain
squatting
positions like
position.
squatting equivalents. Huh. So
Yes,
one thing is this.
equivalence.
Secondly,
Yes,
the
ma'am.
infundibular
Yes,
spasm
ma'am.
is fixed. It gets fibrosed.
Will be the it won't fixed. Yeah.
Huh.
Yes,
It
ma'am.
is not now movable because the spells occur because infundibular spasm
And
is
then
there. But the
physical
infundibula become
adaptation will be
fixed.
there.
It becomes fibrotic. That's why the spells is not there. So one is infundibular spasm is fibrotic. Second is child has acquired squatting positions due to which the spells is not there. Why in squatting position spell is not there? Because when the child squats, the SVR, systemic
So
vascular resistance,
basically,
gets
uh, fe-
increased. Hmm.
Will increase. Yes, ma'am.
Yes. So the right to left shunt will be
Because
decreased.
of
Because
that,
why
right
shunt
to
is there,
left
right
shunt
to
will be
left?
decreased.
I'll just explain this. Why right to left shunt is there? Because PS is there, severe PS. So all the blood which is coming through pulmonary
Pulmonary
artery is
stent.
not
Yes,
going through
ma'am.
pulmonary
Yes, ma'am.
artery. It is going through VSD into aorta. So that's why cyanosis is there
Shunt.
because right to left shunt is there. But somehow, if you increase this aortic pressure also, the SVR also, then the shunt will decrease. It will not completely be absent, but it will be decreased. So by certain maneuvers, if you can increase SVR, like by squatting positions or by folding your legs side by side. These
Yes,
are all
ma'am.
known as squatting equivalents. So that's
Yes,
why the SVR will increase, those
yes,
spells will
ma'am.
decrease, right? And also the fetal hemoglobin
Yes, ma'am.
changes. Third question.
Yes, ma'am.
One of the fellow has hard
Mm.
time remembering and understanding the different specification of CVS examination in different conditions. Why absent P2 and TGA? See, you don't have to mug up all these things. You have to
Hello?
understand. You have to understand these things. So then only you'll recall this. Like if you know why A2 is there, why P2 is there, why A2 is earlier as compared to P2, right? Then only you'll understand. In TGA, as I was telling, that in transposition of great arteries, the aorta comes anterior and pulmonary artery comes posterior. Normally, what is there? Pulmonary artery is anterior and aorta is posterior. In TGA, aorta is anterior
Yes, ma'am.
and
Because of
pulmonary artery is just,
non-spiraling.
yes, the pulmonary artery just hides behind aorta. That's why when you auscultate, you'll just get a single sound. That is aortic sound, right? So if you understand things, if you draw diagrams and see where the blood is going, make arrows and then do this, then only you'll remember. If you just mug up, you won't remember at all. It will all get mixed up. So the best way of learning cardiology is remember the disease, make a block diagram, draw arrows, and then just recognize that which murmur and where all these sounds will be there. Then you'll get to, right? Next question is how to describe the pulmonary and RV apex in X-ray. For RV apex, if the apex is upturned, acute, it is mostly RV, and LV is an obtuse apex. So this is a rough idea of RV and LV apex. That RV is upturned or acute angle. Which
Yes, ma'am.
angle I'm referring to? It is cardiophrenic angle between the heart and diaphragm.
Card.
So this cardiophrenic angle is acute, it is RV type. If it is
Yes, ma'am.
obtuse, it is LV type. And pulmonary artery, you have to see on the second intercostal space. So normally that area is full because pulmonary artery is there. But if that area is opaque or there is no nothing in that pulmonary area, second intercostal space, then we say that pulmonary bay is absent or the pulmonary stenosis is there. Normally, when you see in a VSD patient, that pulmonary area, you have a protrusion. That means the pulmonary arteries are dilated. So you call it PAH. But in this case, the pulmonary area, the pulmonary bay was absent. So this is how you describe this. Yeah, sure.
Yes,
I'll
ma'am.
give my mail ID and always you are welcome. You can always come, any one of you. If you have any doubt in cardiology, like examination, history, or approach, you're always welcome. We'll take classes also and see the patients. I think that's all for today. That's a high dose of cardiology. I hope
Thank you, ma'am.
this is understood
Thank
by
you so much,
fellows.
ma'am.
Yes, then only it's worth if everyone is else
Yes,
has
ma'am.
understood this. You can write down in the comments
Um,
if any issue, any
Thank you,
problem, if
ma'am.
anything you're not understanding, then you can write down. Thank you so much. Thank you. Thank you for the patient listening.
Thank you, ma'am.
Okay. Bye bye.
Thank you.